time. So femur, neck, and shaft fracture in children. So the unique in children is the ossification center. So it's whenever the blood supply is jeopardized in children, either temporarily or permanent, the growth of the proximal femur might be affected on variable levels, according to how much affected and how long it is affected. The classification, I think you all knows this classification. The Delbit classification is a common classification for children neck of femur fracture. It is easy to be applied. So grade 1, transphysial. Grade 2 is transcervical. Then basocervical. 3, 4 should be like intertrochanteric more than neck. The grade 1, because it is more critical, can be subclassified according to the age group. So you can see on B, this is proximal femur fracture, but it is like a transfeasial fracture. Why? Because it is an infant, young child. So as we know, the proximal femur epiphysis, we talked about it before, is a common epiphysis with the GT, which with growth will be separated to 2 epiphyses. So the ossification center will be start to be seen at age around 4 years. So if you have a fracture around that time, you will see a fracture similar to the drawing on C, the transfeasial fracture proximally, around 4 years. If they are older a little bit, around 7 years, you can see the ossification center of the GT, and they start to separate at this level. And the last one, E, is more in adolescent age group. Again, transfeasial fracture, which is related to or similar to the scaphy. So non-displaced, these neck of femur fracture can be non-displaced and can be displaced. If they are completely non-displaced, the result is excellent in general, no matter what the treatment. But what is the treatment? The safest way is the hip spica with the leg in internal rotation, flexion, abduction, for a long period. So 4 weeks or 6 weeks is not enough for this fracture. It has to be minimum 8 to 12 weeks according to the age of the child, according to the healing of the child or the healing potential of the child. If you think the child, his healing potential is slow, you need to go up to 12 weeks, or he's a bit old, to the older side, with a frequent follow-up. Why frequent follow-up? Because they tend to sometimes displace in the cast. So according to the displacement, you might need to intervene. Sometimes minimal displacement, maybe no need to intervene. The same X-rays we've seen before. So at infancy, first year, you cannot see the ossification center before 4 months. Then at 1 year, the ossification center will be larger, but still they are a common epiphysis proximally. Then 4 years, you start to see the ossification center of the GT, and it goes on. What is the importance of this common epiphysis proximally? You need to imagine, if you have a fracture in a young age group at the neck of femur, you will see on the X-ray only the bone. The cartilage, you cannot see it. That means if there is any small displacement in the bone, that means any small displacement and angulation, that means the angulation and the displacement in the cartilage will be more. So accepting displacement or angulation, it has to be very limited, and at the same time, you have to always think in the cartilage, and think in how much displacement there. Small in the bone will be maybe more on the in the cartilage. This cartilaginous is more like posterior and superior. Then with time will disappear, as we said, at the neck level. So in general rule, if you have a bowel angle less than 40, these fracture can be treated with cast without weight bearing. It is important to remember that the same thing I've said before, which is the variability of the thickness of the cartilage along the posterior part of the neck, or posterior superior part of the neck. So accurate anatomical reduction is really needed. So displaced fracture. Any displaced fracture of the neck has a high risk of deformity, like coxa or ischemic necrosis, and close reduction and internal fixation with percutaneous threaded or non-threaded pins is the treatment of choice for this fracture. And where to stop? Anybody can give me where should we stop fixation? Through the physis, just below the physis? Shabab.
Across the physis.
All of them you will cross the physis, Abdulaziz?
I think only one.
You mean only one of the bends or one of the screws?
One of the screws will cross the physis. We will do arthrodesis, our aim. Like I believe it's just like the
scaping?
Yes.
Epiphysiodesis, you mean?
Yes.
Yeah, no, it's not like this. You in neck of femur fracture, you want to have healing of the fracture, and crossing the physis here is not like prohibited, but in the same time is not needed in all cases. Okay, so if you need to cross the physis, like if you have a fracture who's very short from the physis, less than a centimeter, definitely you need to cross the physis. Or if you have, if the bursitis is too weak, that you did your fixation intra-op and still too weak or not holding or moving, or so you need to cross the physis. But these screws or pins across the physis, they are temporary pins. They should not be a permanent one. Why? Because it depends on the age. If you are dealing with a child who's like 14, 13, his growth plate is almost closed, yeah, you can cross and you should not worry. But if you are doing a child who's 3 or 4, he's still growing, definitely you don't want to do, you don't want to plan to do epiphysiodesis, except in a very special circumstances, which we will go through. It is rarely necessary to cross the growth plate, except, as we said, if it is short or weak. So you cross it with pins or even threaded screws, but you plan to remove it as soon as to avoid the interference with the growth. So that's an example of this of a case who had the neck of femur fracture, the same one in the previous slide. As you see, there is a fracture here in the neck of femur. So we can classify this fracture. What grade is this fracture? يمكن الصورة شوية not large enough. It's more like transcervical, right?
Oh, intertrochanteric ولا?
That's good. You said intertrochanteric. If you look carefully, the lesser troch is clear, صح? So there is too much internal external rotation, right? So if you do internal rotation, you can appreciate is it transcervical or basal or intertroch. So that's the same child here. If you look carefully, it's more, it's not really transcervical, it's basocervical. It's not intertroch, right? It's more close like grade 3. Tamam? So in this case, fixation was done, as you see, with screws, cannulated screws in the AB, and the lateral reduction was reasonable. There was some displacement on the superior aspect, but it was reasonable. Cast was applied, as you see, it's a hip spica. So we mentioned before, immobilization is very important in children in general, especially these fractures. So how long do you think we'll leave the spica, Shabab?
8 to 12 weeks.
Yeah, so طبعا without fixation, definitely not less than 8 weeks. With fixation, it depends on the age of the child, depends on the birches of your screws. So if you went intra-op and your birches was reasonable, but you're still worried, as this case, there is minimal displacement superior. أنا لما أكبر تشوف الصورة كذا يا شباب ولا ما تتغير عندكم؟
اللي تكبر يا دكتور.
Okay, yeah. So if you look carefully here, superior, there is still a gap in the top. Okay, so in the top and maybe a little bit posterior. So the fixation is reasonable, but at the same time not very solid. So putting the cast only for 4 or 6 weeks is not enough. So maybe you need to treat this like fracture without fixation. So spike need to be at least for 8 weeks, as you said, 8 to 12 weeks. Why? Because there is a high chance of displacement if you remove it earlier. And unfortunately, this is what happened for this child. Spike was removed at 4 weeks. Surgeon relied on the screws. They thought that the screws will hold the fracture. Unfortunately, in the AB was, you can't tell there is something happened. In the AB, there is more varus. In the lateral, if you look carefully here, there is a posterior gap and there is collapse in the fracture, so there is displacement. Okay, هنا كمان نفس الشيء. This is different. I think that's the first X-ray, the one in the top, and this is X-ray after another visit, 3 or 4 weeks after the first X-ray. So the first X-ray AB was not bad, but still you can tell there is some varus. In the lateral, there is some collapse, there is gap. Still, they did not do anything at this stage, and it was not really clear at this stage. Maybe you can see something, it's not that clear, but definitely on this X-ray you have more gap. Okay, so fixation was good, reduction was good to start with, but I think removing the spike earlier did allow lots of pressure on the long lever arm of the lower limb. As you know, the whole thigh is depending on this link to the hip. So this is, I think it was maybe 8 weeks down the road from the surgery, the lowest X-ray. Okay. So what should we do now? So this this will bring us to the complication. Complication, as we said, there are so many complications. There is high incidence of complication for any treatment method. The complication can be coxavara, deformity, or ischemic necrosis, or delayed union, non-union, ligament discrepancy, and slipped epiphysis, like what you see here. So this child, unfortunately, had a slip epiphysis. And anything else, Shabab, other than slipping? That's
delayed union.
And yeah, either delayed or none according to the time. I agree. So it was a very severe delayed union because he's like, I think 2 to 3 months, maybe 3 months after the fracture. So what should we do now? Epiphysis, slippage, and delayed union. Okay, so طبعا the priority now is for the neck of femur. The options are a lot. Maybe valgus osteotomy and fixation is a good option at this time, but it depends on how good is the bone. If you have a good bone, can you do valgus osteotomy and fixation? If you do a valgus osteotomy, it will be at the level of the lesser trunk. That means you will have like 3 weak links: the osteotomy, the non-union, and the epiphysis. So what I elected to do in this child is just fixing the neck of femur in place and crossing the physis. He's lucky as soon as in the OR after anesthesia, reduction was very easy, not forceful, and fixation was done as you see, 2 screws holding the non-union or the delayed union, and 1 screw holding the epiphysis. And hip spica applied. It was kept for, I think, 3 months. Luckily, he healed, but definitely he's expected to have more complication. Coxavara, yes, yeah, Coxavara, we know about it, and the AVN or ischemic necrosis of the head of the femur. But there is no other option, unfortunately. So we need to.
Doctor,
yes.
Can we combine the osteotomy with trochanteric physiodesis?
Yeah, that's another thing you can think of, the trochanteric epiphysiodesis to prevent future deformity. Wallahi, there is so many talks and thoughts around this. Many people, they said if there is high growth potential, less than 6 or less than 8 years of age, better to do trochanteric epiphysiodesis. For me, I would be reluctant to do it in young age group. Why? Because I know he will go back in a deformity, and he's still growing. Unfortunately, the proximal femur is not growing, or it will stop. We know that it will stop most likely, especially it's a complication. So I would do 1 osteotomy now, then maybe osteotomy in the future. But it's not wrong. You can add the epiphysiodesis. So this is what was done for him. After healing, complete healing of the head of the femur, he had valgus osteotomy, intertrochanteric osteotomy, valgus osteotomy. The head of the femur or the proximal physis is healed. The neck was healed as well. So this osteotomy was done to improve the deformity. And this is him. I think sometimes after healing, as you see, there is deformity. The GT is still open. I did not close it. Why? Because I'm anticipating another osteotomy in the future. I was worried to do epiphysiodesis now for the GT. Then the head will, the neck will continue short. He will need more reconstruction in the future. I thought to leave the GT growing, then I will come back. I'll do another osteotomy when he's adolescent. I think he's around 10 years of age now by this X-ray. Okay, this is him after removal. As you see, start to have another coxavara. So when he's around 12, we'll do osteotomy. It will help me in lengthening the neck of the femur, and it will help me in lengthening the lower limb and at the same time, I might, if the GT is still open, I might do epiphysiodesis. Why? Because he is close to his maturity for the GT I'm talking. Okay, so you need another osteotomy. Head still round, and maybe, of course, it's not like the right head, but still better than complete avascular necrosis. Okay. So that's another case. Yeah, that's another case. Who was a child. This child fell off three floors. And if you look carefully, there is, in addition to the neck of femur fracture, which is close to transcervical fracture, there is ischial fracture. Tell you how much deformity or how much force she had. I think in the pelvis she has maybe that's the only fracture in the pelvis. So transfisial fracture was fixed with screws short below the physis, and as you see there is hip spica. Okay. This girl, still I remember her. I think she was admitted to the ICU. Fixation was not done soon. Why? Because her clinical condition was unstable. So we had to wait, I think, for maybe 5 days or something like this till she was stable. Then we did for her the fixation. The fixation was short below the physis. Birches was good. Reduction was reasonable. Okay, spica was kept for a long time. She had good healing, but unfortunately she had another complication. What is it? Necrosis, aseptic necrosis, or avascular. Yeah. هو طبعا avascular or vascular صراحة it is debatable. I think if it is these fracture, we should call them vascular necrosis. Why? Because it is a disruption of the blood supply, صح? So maybe it's better to say aseptic necrosis. Okay, it's more accurate. Anyway, she has a necrosis of the femoral head, as you see. Fracture healed, but unfortunately she had a necrosis. معلش. Is it the same one? Yeah, that's the one. So as you see, there is necrosis of the femoral head, getting worse, and we can see like a similar picture of Berth's. So there is deformity of the femoral head, and on abduction there was hinge abduction deformity. This is frog leg view. There is early necrosis signs. Fracture healed completely, but unfortunately she survived the fracture, but the femoral head blood supply affected. Again, here there is avascular necrosis. So what should we do for her? She has deformity, abnormal head, limited range of motion, and stiffness. So what I thought to do for her, I thought to do a valgus osteotomy to improve the neck shaft angle, to give her some more length, and at the same time to move the abnormal part of the superior lateral femoral head away from the joint, and like a salvage procedure, and leave the bitter part of the femoral head articulating with the acetabulum. So far she's doing fine. Her motion is better, her gait is better. She is I think she's around 10 or 11. So here you can argue why I did not do the epiphysiodesis. I don't know. I thought she will not need it. She's as you see, her growth plates is very close to closure, so I don't think there is too much remaining growth in the trochanter. But she might grow. If she did grow, and if it is affecting her function or affecting her abduction, she might need distal transfer later on in the future. Okay, so then we'll move to the femur fractures. Femur shaft fracture, you can maybe better will speak about the subtrochanteric fracture, because they are a little bit special than the shaft fracture. These usually result from direct blow for the proximal femur, either accident or during sports. Treatment in general, better to be started by 90 degree pin traction. You're all aware about 90 traction?
I think flexion and axial traction.
So it is 90 because knee 90 degree flexed and the hip is 90 degree flexed, and you will have bend in the distal femur. So unfortunately, you need to take the child, if you're doing this technique, you need to take the child to the OR twice. The first one for the distal femur skeletal traction insertion. It has to be done under general anesthesia to make sure that the skeletal bend is not in the physis. So it has to be above the physis. You apply it, you insert it in the under general anesthesia. Then you take the child, you apply the traction. It will be 90 degree flexion of the knee, 90 degree flexion of the hip. All this to have the proximal, because we know the proximal piece will be flexed and external rotated with the effect of the iliopsoas muscle. So you need to bring the distal femur in the same position easy for the proximal femur, and you wait for some time till you have a good callus, and you apply a hip spica. طبعا the drawback of this is, as we said, twice to the OR, traction, long time in the hospitalization, multiple X-rays. All these are a drawback for the skeletal traction. So maybe in these cases, better to go for fixation, like what you see, elastic nail or plate or pediatric DHS. All this is much better. Anybody can critique this X-ray, Shabab?
Okay, Doctor.
Yeah, تفضل عبد الله.
This X-ray, this is an AP view, pre-op and post-op of skeletally mature patient, showing a proximal femur shaft fracture, or distal to the subtrochanteric, we can say. Actually, we can say that there is, in the fracture side, there is a rotation, flexion and external rotation of the proximal piece. And the fracture mainly, it's looks like a short oblique, or with the butterfly. I don't see it well. And for the fracture fixation, fixed with the thin snail, we depend on this type of fixation, a 3-point fixation. But I can see in the proximal part, I don't know, the nail should be to the opposite side, or it doesn't matter on this fixation. And it looks like there is a rotation at the fracture side. I don't know, is that
after fixation?
El cortex?
Yeah, I agree with you. It is a subtrochanteric fracture, maybe a little bit distal, but still it's a subtrochanteric fracture. The rotation, I think, in the post-op is reduced or corrected. I don't think there is any more rotation. The butterfly can tell you that there is no much rotation. The point you mentioned about the direction of the tens. So if you are doing shaft fractures or with enough space, enough segments proximally, yes, maybe better to have the medial tens, or actually the lateral tens pointing laterally toward the GT apophysis. If it is short segment, unfortunately, sometimes you cannot do this. So you have to go in the neck. Okay. So I think the surgeon elected to go in the neck here, but still, if you go in the neck, try to point them in an opposite direction, one medial and one lateral, to have the best effect of the elastic nails with the 3-point fixation. So I think, yeah, if the lateral pin pointing more lateral, it will be better. In the same time, you need to be careful from twisting too much inside. If the nails are twisted, removal might be very difficult. Like in this case, I think the nails, unfortunately, they are twisted. You can see a cross in the distal segment or the distal shaft, then another cross just below the fracture. So you need to be careful. If you have more than two, they'll be twisted around each other, so removal will be very difficult. Okay. So yeah, I wanted you to point on the direction of the elastic nails. So elastic fixation in general for subtrochanteric fracture, I think it is much better than conservative, unless you have a good indication for skeletal traction 90-90. If you have a good indication, like let's say you have a child with polytrauma, whom you cannot do fixation for him, whom you cannot, or you cannot take your time in the OR. They said you can. He's going for laparotomy, and you have only 5 minutes to do the pin. So you will do the pin and do 90-90. Leave him in the bed for traction till he is stable. Okay. So it is one tool. You should know how to apply it, how to use it whenever you need to use it. Otherwise, fixation for subtrochanteric is much better in general. For shaft fractures, femoral shaft, they behave different than adult. Why? Because they have good healing, so early consolidation is common, and you need to know that they always have a reactive increased rate of growth, approximately in the first 1 or 2 years. This, you should always remember this. Why? Because there is a very high chance of ligament discrepancy in femur shaft fracture, especially if you have a young child. So younger children, better to have some shortening in the cast. Otherwise, you will end up with very bad ligament discrepancy. Spontaneous but limited correction of the axial deformity is expected, but not the rotational correction. So you can accept some angulation in the sagittal view or in the coronal view. In the coronal view, a little bit less acceptance according to the age of the child, but rotation, don't accept rotational deformity. Let me see, there was a slide here hidden. I don't know how can I unhide it. أمس عملت لها unhide بس للأسف did not save, it seems to be. Anyway, خلينا. So femoral shaft fractures in children generally heal easy and very satisfactory with non-operative, with hip spica. However, there is no routine treatment for femur fracture in children. Each case needs to be evaluated and managed according to the age. So in general, children less than 6 years of age or preschool age, you have so many options. The best option of them is hip spica, either direct spica or delayed hip spica. So ممكن ناخذ منكم what are the indications of direct hip spica يا شباب؟ حد يعطينا؟
الايج دكتور.
اوكي الايج، ايش هو الايج يا عبد الله؟
يكون mainly from يعني we can from up to 6 years.
Yeah, so preschool age, that's one. ايش غيره؟
ما اعرف الفراكشر pattern يفرق معنا.
Good age. Yeah. So what do you want to see in the fracture to do direct spike?
we can accept انه يكون في عندنا short oblique type of fracture can be treated with short oblique or even long oblique with casting.
Okay, طيب.
I think transfers, it will be sometimes difficult to maintain it on a spike due to high force will be on that femur.
يعني if you have a transverse in a child who's 4 or 5 or 3, you will go for fixation right away?
No, actually no. But I mean it will be difficult. But
why difficult? Why?
Because it will يعني هو الموضوع الصعوبة بس في موضوع الهيلينج.
Why? What is it? يعني why you think it is more difficult?
We are afraid إنه يصير له أول شيء displacement because of low contact area between the two bones.
Okay, so low contact area, so يعني the healing is less. Yeah, I agree with that. but you didn't need to have anatomical reduction in young children.
No.
You have something called the periosteum, صح?
Yes.
So you didn't need to have anatomical reduction for femur fracture in children. You need to عشان كذا قلنا في السلايد اللي قبلها you need to pay attention for the alignment and the rotation. So the rotation, you need to correct the rotation, number one, followed by correction of the alignment. If you can have the alignment perfect, excellent. How much you can accept, you should know how much you can accept. Next thing you should tell me is the shortening. لو عندك shortening more than 2.5 centimeter,
Yes.
يعني that's not favorable of direct spica, صح? Because it's already short, 2.5, you go for direct, you might have more shortening. So you can do traction, then spica, okay, delayed spica, to have some solid or some healing. But the geometry of the fracture should not change your decision regarding the mode of the treatment. Yeah, if you have shortening with the transverse, maybe you can do traction followed by spica. So first age group, less than 6 years or preschool, you have so many options. One of them is hip spica. So I think the best option is hip spica, followed by plating, followed by or the other options, plating, ايش كمان external fixator, elastic nails اللي هو مثلا قريب من الستة, بس 2, 3, 4 I think it's very يعني it's not the good option to do tense in a child who's young, less than 3 or less than 4 years of age. Is not a good option to do tense. But it's one option. It's not wrong, but it's not the best option. Why? Because you will have anatomical reduction with the tense, and this child definitely he will go in leg length discrepancy in the future. Why? Because the fracture by itself will cause reactive healing, and you did surgery, so it's expected to be faster in growing, so this limb will be longer. The other option may be احنا قلنا Dex fix. Yeah, these are the 4 options, nothing else. The best option in preschool age group is the hip spica, followed by the other options by one. Then it will change according to the case, as we said. If you have an open fracture, if you have a soft tissue swelling or not, you can dictate your management. So the age and the weight of the patient is another important factor, especially in the older age group. Local soft tissue trauma is again important to dictate which type you will use. The location, the type, as you said, Dr. Abdullah. Other injuries to the general, either the head, chest, abdomen, additional fractures of the same limb, all this will play a role in your decision. Infant till 6 months, the best option is the Pavlik harness. Yeah, that's the 5th option. We did not mention it. In children less than 6 months, the best option is Pavlik harness. Even if they are older than 6 months and their body is still small, Pavlik harness is a very good tool in these children. Believe me, I'm not sure all of you know this information or not. I hope all of you know that. But one day I was called from private hospital where a child who's newborn had a femur fracture. Cast was applied for him, and unfortunately he had an ischemia. Luckily they called me early. We removed the cast and the limb was saved. Pavlik harness was applied, which is very simple, and healing in two weeks was solid like a rock. Shortening less than 2 centimeter, angulation less than 15 degree with correction of the rotation. These are the major goals to achieve when you apply the hip spica. Immediate is a very good option in preschool age group in general. So you see this fracture. I think he was like 4 or 5 years of age. It's a long oblique to maybe or spiral, more toward long oblique. And as you see, there is mild valgus. there is no much rotation. Shortening, minimal shortening. So he's a very good candidate for direct spica. Okay, spica applied for him. This is him in the spica. So in the fracture, yani, you would say it's a spiral more than long oblique. Anyway, what do you think, guys? Direct spica was applied for him. Shortening looks a little bit more than pre-op, as well as the angulation. Let's take a vote يا شباب. Who will keep the spica? أحمد أنت تشوف الشات عندك ها؟
أيوة.
I cannot see the chat. Who will keep the spica?
Abdulaziz remove.
Okay.
How old, doctor?
He is 4 at this X-ray.
Abdullah Sawaf want to keep. نجوى براء to keep. حتى الساعاتي. عبد الرحمن بن موحي يقول remove.
Remove, huh? So remove and do another fixation and or to keep. طيب, this brings us to how to do the technique of spica يا شباب. All of you are aware how to do the spica for hip spica for femur fracture. I hope.
لو ممكن نقولها بسرعة دكتور بعد إذنك.
طيب تفضل قول يا أحمد.
طيب طيب we keep the hip we correct first the rotation. Okay.
ممتاز.
And then keep the hip flexed and slightly abducted around 30 degrees. And
okay.
the hip flexed.
Okay.
And then we apply the spica and mold it in valgus.
Okay, ممتاز. طيب هو I agree what you said. Maybe the abduction 30 degrees is a little bit exaggerated. In DDH, yes, you need to go to 30 to 40. But in hip fractures, I mean in femur fracture, is a little bit different. So you need to have a little bit abduction for the hygiene, but you should not reach the 30. 30 شوية كثير. You want to be a little bit less than 30. 20, 15 to 20 is reasonable. That's number one. Number two, you need to know which technique you're doing. There is from distal to proximal or proximal to distal. All are right, but each technique has its own advantage and disadvantage. So if you're doing it from distal to proximal, so you're doing below knee first, then the thigh, then above around the abdomen. That's a good technique to do molding and to do it reduction for the rotation as well as for the shortening. But in the same time, you need to be careful from pressure on the calf muscles, because there is high chance of compartment syndrome. So if you're doing below knee first, you need to have enough padding in the posterior. You need to wait till the cast is hard, so you can do it only with Dynacast. If you do it with the plaster of Paris, you will have the cast pressing on the calf, so you'll have pressure at the calf and compartment syndrome there. So after doing the below knee cast and make sure it is oval shape, not pressing with the calf, you can control the distal condyle and do traction and do the rotation, correct the angulation, go proximally and mold it in valgus. Very important. This is very important. You have to mold it in valgus. Why? Because these fractures, they tend to go in varus. So mold it in valgus. Allow some degrees of valgus is fine. Why? Because they tend always to go in varus. Then go above. And if you want to do it from the abdomen to distal, you can hold the position as we mentioned earlier and mold the cast in valgus and do it 1.5 if you think the cast is not strong enough. So this child
معلش انه مع الفالجس كان يبوت ان ريكارفاتا برضه نفس الشيء ولا
ريكارفاتا ليش؟
ايوه برضه عشان الفورسز يعني
No. Recurvatum, no. Only valgus. Why? Because they tend to go in varus in the cast because of the position of the thigh and the bulkiness of the thigh. But on the lateral aspect, you want to be straight. Okay. The next thing is the position of the hip and the knee. So if you have a child who's close to school age, better to go for 90-90, like a sitting position. If you have a child who's only a baby, who's only 1 or 2 years, he's lying most of the time, it will be more close to the lying position. So the age of the child will dictate how much flexion you will do in the knee and in the hip. If you are doing it even in the school age, sometimes you can do spica in 6 or 7 or 7 years or even 8 years of age. It's not a wrong option. It's one of the options. It's not the best, but it's one of the options. Sometimes any situation will put you in only one option, so you have to do a spica. So you have to put it in a sitting position for the child not to miss school. He can sit on the chair with the spica and goes to school, and even transfer and mobilization by the parent transfer will be much easier. So this child was kept, spica was kept, we did not change it. And this is him, I think, after 1 year. Usually I don't do a long film, but the father was really worried from the ligament discrepancy. So I had to do an X-ray and to show him that nothing is there. And he did great. Angulation improved. The valgus we mentioned, as well as the shortening is improving. He was followed clinically till his leg length were equal, no discrepancy. While if you reduce it 100%, you will have the other, you have the opposite. The broken leg will have overgrowth, and they will have leg length discrepancy. The other option is elastic nails or X-Fix. All can be used according to the age of the child or according to the situation of the fracture. In adolescent age group, you need to know the age of the child. Why? Because the other option which you can do is the rigid nailing. If you have a child more than 40 kilos or 50 kilos, you can go for rigid nailing. In general, more than 12 or 13 years of age is good for rigid nailing, provided that you have enough canal diameter. The good thing nowadays, we have the adolescent nails or pediatric nails, where you can use them in a narrow medulla, but definitely you will not use them in a young child. Why? Because of the blood supply of the femoral neck. You don't want to have any chance of AVN. They are growing children. Having the nail entering the canal from proximal might jeopardize the blood supply. If you have to use it in a younger age group, make sure you use the trochanteric entry, the adolescent nail, or the pediatric age group nail. Complication, we mentioned some of them, which is the leg length discrepancy, malunion, either angular or rotation. Refracture is another complication, growth arrest, nerve and vascular injury, myositis ossificans is one of the complications as well. So take home message, history should be covered completely because of child abuse. As we know, femur fracture, you should always consider the child abuse because you need to have significant energy to break the femur. So child abuse need to be inquire in your history. Should be you should ask about it or suspect it. Femur neck fracture are serious with a high complication rate. Immobilization with hip spica is frequently needed, even with fixation. Anticipate complication for the femur head or for the femur neck fracture, and look for them in the follow-up. Thank you. The references was skeletal injury and skeletal trauma by Ogden and Green, two references.
الله يعطيك العافية دكتور.
عندكم أسئلة يا شباب؟
دكتور الله يسعدك، في الكيس اللي قدمت أول حقت الترك، ماني عارف هل يختلف معانا موضوع الكونفجريشن حقت السكروز، إن هل كانت هي سبب في الفيلير؟ هل لها علاقة بالشيء ده ولا لا ما لها علاقة؟
أول واحدة اللي صار فيها سليبج.
أيوة نعم.
Yeah, it was trans-cervical هذيك trans to maybe base. It was not intertroch. So I think the only thing which has happened is the removal of the spike, because both of them, even the other one I presented, the one has AVN, the fracture healed. Okay.
Yes.
And the reduction, they were almost the same, to be honest with you. But the second one I presented is the spike was kept for a long time. The spike was kept for 3 months, and she had a good healing of the fracture. But unfortunately, she has an AVN, which is secondary to the fracture. It's not related to the fixation. While the first one, fracture fixation, was good to start with, spike removed early, unfortunately. So the fracture displaced, then slippage has happened. So because that I mentioned it for take-home message, and spike immobilization is really needed to be long in these children.
Doctor, if we need to cross the phases for neck of femur fracture patients in pediatric, firstly they can't transphysial fracture. Screw placement, we avoid the anterolateral. I read slash we avoid the anterolateral quadrant.
In the neck itself.
And yeah, in the neck quadrant حق النك قريت إنه we have to avoid the anterolateral. بصراحة ماني عارف ليش.
Yeah. They mean because of the blood supply is more superior. So maybe I don't know. Maybe the pronunciation or the direction they miss. I don't know. But the blood supply we know from superior, posterior, from the posterior and superior. So if you have the screw going out of the neck, you might be very close to the blood supply, because that you want to avoid it. But in general, crossing the phases by one screw is safe, or one Steinman bends, smooth wire. Then you have to remove it. I had another case, unfortunately I couldn't show it to you. I did and hidden the slide. We crossed the phases, we kept it there for about 2 months, about 8 weeks. Then we removed the screw and we exchanged it by another screw after we saw good healing of the fracture. But you have to make sure all the screws are in the neck. Why? Because it's very common to have the screw coming out of the neck, then going in the head again, and this is the risk of AVN. Why? Because it will press on the vessels, or it will affect the blood supply without you knowing. Oblique views, more than position, intra-op is very important. AB lateral and more obliques to make sure that all the screws are within the neck. The neck is very small. Sometimes you cannot do more than 2 screws. طبعا size of the screws, عارفين قديش you use the size of the screws? According to the age of the child, if you have adolescent age group, you can use the adult size, 6.5 or 7.2. But in younger children, you cannot use this large size. You have to use 3.5 or 4 millimeter. So if the neck is too small, you cannot do 3 screws. Two is more than enough. If you try to put a third one, you will find yourself going out of the neck. I think the point you mentioned is because of the blood supply. It is just running parallel to the blood, to the neck, and if you are there in that area, you might go out of the cortex and affect the blood supply. Any other question?
الله يعطيكم العافية دكتور.
بالتوفيق يا شباب.
شكرا جزيلا دكتور.
عفوا.
شكرا.